Good morning. Welcome to today's Ethnic Media Services News Conference. I'm Sunita Sarabji, Health Editor at EMS and your moderator today. As we begin, I'd like to acknowledge that many of you are joining us from Southern California and facing mass devastation from the wildfires, and we sincerely hope that you all are keeping safe. As we begin 2025, people around the world and in the US are facing a host of public health threats, including avian flu, norovirus, Oropouche, human metapneumovirus, Mpox, as well as the ongoing challenge of COVID-19. Speakers today will discuss each of these illnesses in depth and tips to prevent and keep ourselves safe. We will also discuss whether the challenge, which is traditionally the global leader in managing health crises, is adequately prepared to manage what awaits us. Our speakers today are Dr. Nahid Bhadelia, founding director of the Center on Emerging Infectious Diseases at Boston University, Dr. Peter Chin Hong, an infectious diseases specialist at the University of California, San Francisco, Dr. Benjamin Neuman, professor of biology at Texas A&M University, Dr. Maurice Pitesky, who will be joining us a little bit later, doctor of veterinary medicine at the University of California, Davis, and Dr. William Schaffner, professor of medicine in the Division of Infectious Diseases at the Vanderbilt University School of Medicine. We ask panelists to speak slowly for our interpreters in Spanish, Mandarin, and Korean. We ask reporters to enter questions into the chat, and we will take as many of the questions as we can during our roundtable discussion today. And speakers, please feel free to ask questions of your fellow panelists as we move along. So let's begin with a question for all of you. What is at the top of your list for public health concerns we are facing? Let's start out with Dr. Bhadelia. Dr. Bhadelia, what do you see as the biggest challenge facing us?
Oh, can I only have one? Because certainly I think that list is long. So I know Dr. Neuman mentioned before we started concern about vaccine disinformation, misinformation, distrust. So let me start stepping back a little bit from that to say I'm actually concerned about just climate change overall and the impact that that's going to have on spread of infectious diseases, on lack of predictability about where they show up, what their, how much more they may manifest than they did before because of the change in the vector and their distributions, as well as other vulnerabilities to healthcare systems. It's sort of, you talked about what's going on in LA. We're seeing weather-related disasters manifest, that those are not infectious diseases related necessarily, but they have secondary impacts, including on medical supplies, on use of antibiotics, et cetera, as well.
Yeah, absolutely. Dr. Chin Hong?
I'm glad I'm going second, but because again, like Dr. Bhadelia, there's so many things to choose from. But if I had to choose one organism, I think influenza. I know others will mention that too. Both, not only bird flu, which we're talking about a lot in the media with both humans, but particularly animals suffering, including domesticated animals, but human influenza, which is again beginning its rise now. And I think to Dr. Badelia's point, I'm worried that, the sort of anti-science movement will make people not take advantage of all the tools that we have.
Yeah, absolutely. We're going to address that further in this conversation. Dr. Neuman.
Yeah, so I'll stick with under vaccination as a threat. And I think what we're going to see over the next couple of years, vaccines that are not compulsory, so vaccines that adults would take, are being taken at a much lower level across the board. And so we may see some of the safety net of herd immunity that has been protecting us since the mid 1900s lifted. And who knows what that will bring, along with the shifts that are unpredictable from things like climate change. I would also say I am somewhat worried that the required vaccinations, like for school children, may be modified or may be lessened. And that's kind of the last bit of the security blanket that definitely remains in place now. So those are my concerns.
I'm going to ask you more about that, Dr. Neuman, as we continue this conversation. Dr. Schaffner.
Well, I'm going to speak in concert, sing in concert with my colleagues. Obviously, climate change and its implications are enormous. I'm also concerned about vaccine hesitancy and skepticism. But for the moment, I'm focused on influenza, regular seasonal influenza, the way Peter did, because our emergency rooms and hospitals are full of people now experiencing influenza, and COVID is on the rise in my neck of the woods, and RSV, although a little bit later than usual, is also starting to stick its nose up. So we have plenty of respiratory viral infections that are affecting our population right at the moment.
Yeah, and a follow-up question for all of you before we circle back to Dr. Bhadelia. How is climate change impacting these respiratory viruses? If one or all of you could weigh in on that, that would be terrific. Dr. Schaffner, would you?
Well, we're obviously indoors, very, very close together, which provide ample opportunities for these viruses, which like to spread closely from one to another. There's been an awful lot of traveling and parties and family reunions that have occurred over the wonderful holiday season that we have experienced that have worked as accelerators to enhance the spread of these viruses. And particularly as regards influenza, now that children are back in school, they of course have the distribution franchise, if you will, for the influenza virus. They'll spread it amongst themselves and then bring it home and give it to their relatives and neighbors.
Thank you. So this is an excellent segue back to Dr. Bhadelia. In a recent article you wrote for STAT, you mentioned the global health cliche: what circulates in Congo today could be in Colorado tomorrow. Could you, Dr. Bhadelia, discuss why this largely rings true despite it being a cliche?
Yeah, I think cliches are cliches because they're well-trodden truths, because they ring true with experience. The article writes about the potential U.S. withdrawal from global community, which is, I think, part of the issue here. The U.S. has played an incredible role in creating global health security infrastructure in a couple of ways. In the work that we do in helping countries build and support their health systems in collaboration with our global partners like World Health Organization, but also direct bilateral. So I actually played a role in the Biden administration. I was the White House, part of the White House COVID response team as a senior policy advisor for our global COVID response. And in that, I coordinated our interagency vaccine donations globally. And the reason we were able to take advantage of that is that we have decades of relationships through programs like PEPFAR from the CDC's Global Disease Detective programs that are based in Global Security Bureau, work that we've done through even DoD, the Naval Medical Research Units that are based everywhere that have done a few things. They've increased technical knowledge. They have ensured distribution of diagnostics so that if there's a signal that we're there with our partners, potentially detecting new pathogens more quickly and helping them as needed in ensuring that that's reported up in a timely manner according to international health regulations. But we're also doing two other things. Programs like PEPFAR, which at baseline have had huge amount of bipartisan support and have saved 26 million lives. It is the thing, right, that we've done as a country in the global health community that's changed the shape of the arc of that pandemic with HIV is now potentially on the chopping block. And PEPFAR during the COVID-19 pandemic had an additional benefit of being also serving as a swing resource where we could add diagnostics for COVID-19 and use it as a platform on which to help with pandemic preparedness. I think that those things have helped us in building trust and picking up potential signals before they become a threat within our own borders. And that's where I'm concerned that perhaps that may not continue under the next administration or maybe reduced.
Yeah, so to follow up on that, former President Joe Biden called several meetings of Quad nations in 2021 and 2022 to discuss the COVID-19 pandemic. Do you expect the Trump administration will follow this lead and continue to meet with members of Quad nations, and especially in the developing world, to mitigate the risk of future pandemics?
Yeah, I mean, it is my hope that they see the benefits of the Quad relationship. Certainly, that played a big role during COVID-19, particularly around, investing. In my part of that little world was around vaccine distribution, vaccine, right, sharing. But beyond that, the concern that I have is during the first Trump administration, the U.S. withdrew from the WHO, and I'm hearing that that might still be the plan. The reason that affects our ability to be part of the global security framework globally is that WHO serves as a technical platform and a vehicle through which countries can participate and share data. And if we withdraw from that, that's only at our own peril, to miss out from that global community. The other things that I hope that we don't see play through is that there have been statements through some incoming senior officials that they will reduce investment in infectious diseases or delay research. I mean, what a travesty that would be, because as Dr. Neuman or Dr. Chin Hong said, H5N1 is on our doorstep. We're seeing new tools that could be used in multiple ways, like synthetic biology and AI, right? If we take our foot off the pedal, we are doing so at our own peril, and we're not being prepared. And we're going to see America's competitiveness as well as its membership in the global community suffer from that.
Yeah, so Dr. Bhadelia, one final question from me. If we geopolitically isolate ourselves medically, is the U.S. equipped to handle the public health challenges coming from abroad?
Oof. Are we able to handle the ones within our border?
Yes.
I think that COVID laid bare the fact that even within the United States, we need a long way to go around health equity in rural areas, in areas that are under-resourced in terms of access to medicine. I think we need to continue to work on that. What we found is, new outbreaks, new epidemics tend to affect those of us who are most vulnerable at baseline. And you can see that in some ways with the H5N1 scenario. It is the vulnerable migrant workers that are potentially at highest risk, who maybe have a delayed access to care or potentially some language barriers there. I think we have a lot to work on within our borders, but I think that if we withdraw from our global health security partnerships, we will be in the back of the line in learning about new threats, and potentially we will lose the trust of our partners to take the timely actions that are needed to exchange samples, to ensure diagnostics are in place so that outbreaks can be handled where they grow or where they may manifest, whether they be in Missouri or in Uganda. So I want to ensure that it's not just abroad that these diseases emerge, it's also here. And I think we just have to see it as a continuum. And if we don't do that, we're at our own peril.
Thank you. We have a question from Henrietta Burrows of East Palo Alto today. Henrietta, could you please ask your question? And just a reminder to all speakers, I'm getting alerts from the interpreters to please speak slowly. So if you wouldn't mind, that would be great. Henrietta, please ask your question.
Thanks so much, Sunita. I had just prefaced my question with the fact that HMPV had not been mentioned, and then Dr. Bhadelia mentioned it. So I am wondering, this is the virus, I think it's a virus that's causing considerable problems in China. Now, could this be the new COVID-19? I read that it has reached the US, and how much concern should we have in terms of it? And is there some type of immunization or some type of inoculation that's being prepared for it?
So Henrietta, Dr. Schaffner is going to address much of that, but let's have Dr. Badelia's take on it as well.
Yeah, I think I'm not going to say much because I know Dr. Schaffner is going to talk about it. I'll just say the picture is evolving. Human metapneumovirus is something it circulates similar to RSV, right? And what I'm trying to get a handle on with the current situation is whether what's happening with HMPV, and Dr. Schaffner may have more input, is simply this change in the epidemiology that we're seeing with many of the respiratory viruses because, COVID-19 happened. We changed the way we interacted with each other. And so we saw, of course, the triple demic that we were talking about a couple of years ago. So this is a manifestation of a delay, right, in exposure to circulating viruses or something new. And I'm sure Dr. Schaffner may have something to add to that.
And Peter Sherman has a question for you, Dr. Bhadelia. Peter, please ask your question.
Hi, thank you, Sunita. I have a two-part question, but maybe I'll start with the first and leave the second for later. Communication clearly became an issue during the pandemic, during COVID. Trust. What have the speakers and panelists, including Dr. Bhadelia, learned about how we communicate these sorts of things to the public in a way that doesn't just turn them in the other direction or be taken as misinformation, that sort of thing. Thank you.
Yeah, I want to, Peter, we did my center, the Center on Emerging Infectious Diseases. If you go to our website, I'll drop the link. We did actually a huge literature review and put together a bibliography, a high yield bibliography of all the lessons learned about building trust in public health communications. I found that to be very useful in my own work. So the first 2.5 years of the pandemic, I was an MSNBC medical contributor. And I have to tell you, it was trial by fire because the number one lesson for me was how do you communicate scientific uncertainty without getting people uncomfortable with the idea of the fact that the person who's speaking about this may not have all the answers. And I think the number one lesson we've learned is humility, the ability to say we don't know, and here's why that knowledge matters, what may make a difference of. But the work that we did in tracking the other studies that have done this work have showed that to build that trust, you need to show up in person to those communities that you want to interact with. And you need to have longitudinal contact with multiple points of contact over time. And you need to be focused on more than just the one disease you care about. And that has been the experience with the Global Polio Eradication Initiative as well. If you look at the lessons learned, often it is that you can't look at one need of a community in isolation. You have to understand that community, have multiple points of contact, and show up in person, and show up with humility and wanting to learn.
Thank you so much, Dr. Bhadelia. There are additional questions for you in the chat, and maybe you can answer them there, and we will circle back to you for more questions. So before we move on to Dr. Schaffner to discuss norovirus and HMPV, I would like to call upon EMS co-director Julian Doe to briefly discuss his family's experience with norovirus. Julian, could you briefly share what you and your family went through?
Great. Yes. Thank you, Sunita. We were in Texas for a family Christmas, and it turned out to be a memorable one, not in such a great way. So we arrived in the Dallas area on the 23rd. And we went to a seafood restaurant, and our family had a tray of royal oysters. And immediately that evening, we felt something was not wasn't right, and we thought it was food poisoning. But one after another, and it started with me, that we started to vomiting and having a constant diarrhea. And this went on for an excruciating 3 straight days. And so we didn't get to enjoy the Christmas of the 23rd, 24th, and 25th, and missed the whole thing. But so we looked it up, and it turned out that we might have caught Norovirus because it had all the symptoms. And so all I could share is that it was unfortunate, and it's an experience that we definitely didn't want to happen with anyone else. And I think because it was a cold weather, and we were all cooped up together in a house, and that made the situation worse. So that was my situation.
Thank you, Julian. I hope you and your family are feeling better.
Thank you. Yeah, we have.
Yeah.
Yeah.
So, Dr. Schaffner, is Julian's experience typical of what a person faces when stricken with norovirus?
Well, unfortunately, Julian's experience is very typical, and that of his family also. Fortunately, as he said, for most people, it's 2 or 3 days of misery, and then people do get better. In this season of respiratory viruses, this norovirus is an intestinal virus. It is extraordinarily contagious. It takes very few viral particles to initiate an infection. It is spread through close personal contact. This virus can also persist in the environment, so you can pick up small amounts of virus on your fingertips and put your hands on your mouth and thereby initiate an infection. As Julian said, it can also be transmitted through food, oysters, filter water, and they can accumulate noroviruses occasionally. And so he and his family, a norovirus foodborne outbreak. This is a virus that we call indelicately winter vomiting disease.
Oof.
You can get it during any time of the season, any time of the year, but it does have an increase in the winter time, perhaps also because we gather together, travel closely together. These are all opportunities for it to spread. Our treatment is symptomatic. Most importantly is that we have to keep up with our fluids, because we can lose fluid through vomiting and through diarrhea. And so we wish to restore our fluid balance. Don't drink a lot at once. Keep sipping clear liquids. Those sports drinks work very, very well. As Julius asked, there's no vaccine that we have available, at least at the moment. There is one in the research pipeline, but it won't be available yet this winter. Hand hygiene is very important, and here's an important point about hand hygiene. The hand hygiene wipes and gels that we use are not effective against the norovirus. Old-fashioned soap and water is what's important. Do that frequently. And of course, avoid people who are sick.
Interesting. So, Dr. Schaffner, should we be suspect of any raw shellfish, given that it can be transmitted, as you mentioned, through oysters, for example?
Well, as a lover of raw shellfish,
yes,
I would say we should be judicious. And we really can't anticipate when norovirus will occur. The people we caution about raw shellfish are people who are immune compromised. And if you have substantial underlying clinical illnesses, particularly those that relate to the liver. That has to do with another infection, Vibrio vulnificus, but nonetheless, those people should be cautious about eating raw oysters. Enjoy oyster stew instead.
So we're going to switch gears to HMPV, the human metapneumovirus. We're seeing a pretty significant outbreak in China, as was mentioned earlier. Do you expect to see an outbreak of HMPV in the US as well?
We have an outbreak of HMPV each year in the United States and everywhere. HMPV, human metapneumovirus, is a well-known virus to the infectious disease and public health experts. It's something new to the general public. And so far, this isn't, well, I should say it's another respiratory virus. It's related to RSV. It has a particular impact on younger children, as does RSV, but it is a virus where you can get infected numerous times during your lifetime. And we recognize that older, frail people can have complications from human metapneumovirus. The outbreak in China has received a great deal of publicity, but the Chinese public health authorities have said, please, this is within normal limits of what we see during the winter. So I think we can be becalmed about that. Human metapneumovirus is not going to cause a global pandemic.
Interesting. I'm sorry, once again, could you please explain some of the characteristics of HMPV?
Well, HMPV is a respiratory virus in that it is in the larger group of influenza, COVID, and RSV. It is most closely related to RSV, and we know that virus, as well, HMPV, affects children predominantly, but also can affect adults, and particularly older adults, and make them more seriously ill. We know less about it because our diagnostic capacities have not been as widely available in the past. Going forward in the future, I expect as we have more accessible and less expensive diagnostic tests available, we'll learn more about HMPV. But I wish to emphasize, HMPV is a virus that has been very well known, particularly to virologists who are investigators. I'm sure Ben is smiling. And this is a virus that we anticipate being active all over, including in the United States, every winter season.
So, Dr. Schaffner, why has it come to our attention at this point?
Well, it is wintertime and HMPV has increased, and our capacity to know what's going on around the world, the surveillance system that Dr. Bhadelia mentioned, has improved. And the Chinese authorities appear to be more forthcoming than they have been in the past. And we know about this, but this does not mean that we are going to have a global pandemic of HMPV in any way related to COVID.
Thank you so much, Dr. Schaffner. We will have additional questions for you towards the end of the call today. We move on next to Dr. Peter Chin Hong to discuss Mpox and Oropouche, two viruses slowly making their way into the U.S. Dr. Chin Hong, the first case of Mpox in the U.S. was detected last November, right here in the Bay Area. Do you expect to see an outbreak this year?
I don't expect to see an outbreak of this particular clade or type of Mpox in the United States. However, the type that started circulating in 2022 is still very much around us. And I'm worried that people have sort of forgotten what that means and are not keeping up with vaccines. But this particular clade 1B, the reason why it's a public health emergency of international concern called by the WHO, the second time for Mpox in a few years, is because it's acting a little bit different from the original Mpox, which was clade 1 in Africa, and is causing a lot of deaths, more than 50,000 deaths. I'm sorry, more than 50,000 cases and more than 1,000 deaths, mainly in children under the age of 15.
Wow.
So maybe it's confusing to people because of the letters and numbers, but I'll just, in 2 sentences or so, just put it in context. In the original, the OG, so to speak, of Mpox was in the 70s, and that was clade 1. You mainly got it from contact with animals. And it's related to climate change too, because of deforestation, as people look for better ways to grow crops, etc. And clade 2 was seen in the United States and about more than 100 countries in 2022, causing more than 100,000 cases. And that's clade 2, and that's mainly sexual contact. So the in-between clade is what we're talking about now, which is clade 1b, which is not just seen by directly interacting with animals. It's also spread through sexual contact and in households, but acts more severely than the type we saw in 2022 around the world. And that is why it's a public health emergency of national concern. Also, it's a way in which we could divert resources to the places that have it the most before it spreads and becomes a bigger threat in more countries. In fact, it's in about 12 countries outside of Africa right now.
Interesting. Just yesterday, China announced it had identified a new strain of Mpox. Is that the clade 1b
Yes,
to which you're referring?
Yeah, so whenever there's a report of a Mpox being found in a country that's the new strain, it's that in-between strain, between 1 and 2 that has features of both. It's more like 1 because it's probably more serious and can cause more extensive disease, maybe cause more serious illness. But it's more like clade 2 because it's not just contact animals or sexual transmission. It's a little bit of both, including household transmissions.
And you remarked that the large number of deaths had been identified in children under 15. However, you also said that the disease is transmitted primarily through sexual contact. So could you talk about that a little bit, clear it up? Yeah.
It's not primarily through sexual contact. That is a possibility. That is how it's different from the original clade 1, which was originally identified in the Congo. But I guess it's more, there are many ways of getting this particular clade 1b. That's not just interacting with animals or through sexual contact. It's a little bit of both. And that's why so many kids are affected because it's spreading in households of people who've come into the household and maybe spreading more efficiently. The other aspect about it is that there are probably aspects of children's health in Africa that maybe not generalizable or different to kids in the United States and elsewhere, which is co-infections with other diseases like malaria or even measles and malnutrition and conflict. So there's a lot of conflict right now in Congo, bringing people together in very close quarters.
Right. There are 2 vaccines against Mpox currently available. Would you recommend these vaccines and who should take them?
Yeah, so there's only one in the US, but 2 globally. And the one in the US is Jynneos, the one that was used extensively starting in 2022. Before that, there was another type, but this one is a little bit better and safer for children. The main population that's at risk, and again, the main point is that even though we're sort of wowed by this new clade 1b, the clade 2 that was circulating starting in 2022 is still causing hundreds of cases and more in the United States every year. That vaccine, Jynneos, is recommended for gay and bisexual men or people who are in contact with Mpox as reason of occupation or research. 2 doses, 28 days apart. There's some studies showing that only about 1 in 4 people have completed their series. So there's still a long way to go with that. The other vaccine that's available and which is being targeted for Africa right now as another vaccine is one made by a Japanese company called LC16. It doesn't have a really exciting name yet. But that is another alternative that the world can have at their disposal.
Thank you. Switching gears briefly to Oropouche, and reporters we have an excellent interview with Dr. Chin Hong on Oropouche on the EMS website. So I urge you to go there to look at the full interview. So Oropouche was first identified in your home country of Trinidad, and we now have 94 cases of Oropouche transmissions here in the US. Do you expect to see an outbreak of Oropouche this year?
I don't expect it in the United States, but we're seeing an explosion that's unprecedented, particularly in South America right now and in the Caribbean. And that's, for reasons we can speculate, including deforestation, climate change, all of that. And that increase is even shocking to anyone. I mean, Brazil, for example, reported about 300 cases a year ago, but this year it's more than 10,000 cases. And that's why it's spilling over into the US with the number of cases you mentioned, Sunita. We have that mosquito called Culex, which also transmits West Nile virus. But there are other features of the infection that you need, like decaying banana stumps and things like that, that isn't really quite right on other animals in the midst for the transmission, person to person in the US. However, sexual transmission has recently been identified as a potential way to transmit it. So you can imagine travelers coming back unknowingly having Oropouche virus and transmitting it to their sexual partners.
Yeah. And you had mentioned that it is transmitted through these midges, these small biting flies. Are mosquito repellents like DEET and jungle juice effective against bites from midges?
Yeah, so even though I mentioned Culex mosquitoes, the main way of getting Oropouche virus is through these midges, which are these tiny flies. They're also called no-see-ums. They can go through, it's like a science fiction movie. They can go through mesh that people put up to repel insects in homes. It's not really clear whether or not mosquito repellents that we use work. So more research is needed for particularly midges. But, what people recommend is DEET 10 to 35%. So I'd probably go on the above 20% DEET. And picaridin is another, 20% is another repellent that people use. But I probably won't do some of the lower evidence-based repellents like citronella and some of these ones that smell better, but they're not quite as effective as the others. At the end of the day, it's probably going to be a variety of things that people do, including, insecticide coated clothing. That's also an adjunct, mosquito nets, things like that.
Thank you, Dr. Chin Hong. We'll have some additional questions for you. We move now to Dr. Ben Neuman to discuss COVID, to give us an update on COVID. But first of all, there is a question for Dr. Neuman from Peter Sherman. Peter, could you ask your question?
Hi, sorry, I was on mute. Thank you. I was curious with sort of the potential for confirmation of Robert Kennedy as head of Department of Health and Human Services, what impact that could have in terms of funding for research at this critical moment as all of these threats are emerging. And as a very sort of comedic aside and compliment, in my view, Dr. William Schaffner to me sounds a lot like Stan Lee from Marvel Comics. So hearing Stan Lee's voice. In any case, that's my question. Thank you.
Dr. Neuman.
It's not clear how much of what Mr. Kennedy is saying is just hype and words and how much is going to be action. But I can confidently say that if he carries out everything he says, it would gut the infectious disease research landscape in the United States of America. That's a thing that may not have immediate consequences because the process of going from a new virus to a new vaccine or drug takes several years. But when you shut off the pipeline, it creates this downstream effect where eventually nothing is going to be coming out. So that is very much my concern, and we will see how that plays out.
And to follow up with that question, Dr. Neuman, you had mentioned at the start of the briefing that you expect that some traditional vaccines for children may not necessarily be mandated. Could you talk about that a little bit?
Sure. So since we've had vaccines associated with school, those have been a big part of the eradication of polio, for example, which is a disease that a lot of younger children catch. There is still a little bit of viruses like this and these other easily preventable viruses out there. And if the immunity of the youngest group, who are the most susceptible and, as Dr. Schaffner said, the most likely to spread the viral franchise, or however he put it, if these are no longer protected, then I think we'll see a lot of spillover into older people, parents, communities, and we don't really know what the effect will be, except to say that it will be bad and it will be more of these viruses.
Interesting. Are you expecting to see spikes in whooping cough, measles, chickenpox, things that are traditionally protected by vaccinations?
It's depressing, but yes.
Yeah.
What we are seeing is a very large decrease in the vaccines that are not obligatory. So things like the flu vaccine. If you compare the amount that have been delivered this year, it's 11 million doses less than were delivered by this point last year.
Wow.
Compare it to 2020, it is 49 million Americans who are not vaccinated this year compared to then. So you're talking about something like, 15, 20% of the country. And we're seeing that in the numbers of virus infections, not only in hospitals, but usually there are two main types of flu virus out there, the H1N1 and the H3N2. Normally, H3N2 is harder to control, and we have less success with the vaccines. And normally, H1N1 is effectively stopped by the vaccine because it's a more recent virus. It's still closer to the root. We are seeing about equal numbers of both of those out there, and that is disheartening.
Interesting. We wanted to get an update from you on COVID, as we've been doing over the past 4 years. We now have the highly transmissible XEC subvariant making the rounds since October. Will we see a spike this winter, especially as we also face down the triple threat of RSV, flu, and norovirus?
I think the interesting thing about this year's winter virus season is that we have resynchronized all of those old illnesses. Pneumoviruses, noroviruses, RSV, coronaviruses are all hitting at around the same time as the flu virus. And this has not been the case since the year of lockdowns in 2020. So I think this shows that it's not so much that these viruses have a season. The seasonality of these is probably driven by what we do and how we gather, essentially.
Yeah.
What was the rest of the question? I missed it. Yeah.
No, you did answer the question. Are there new COVID vaccines in the pipeline? And are companies continue to produce new vaccines as these subvariants emerge?
With lower numbers of vaccines delivered. So for the US, it is very difficult now to actually get the data for who is vaccinated. And some of the old data that broke down vaccines by ethnic groups is not publicly available anymore. And for COVID in particular, it looks as though around 8% of the US population has had the new booster, and previous versions of the vaccine would not protect against infection with the new strains that are circulating. While the XEC variant is fairly large right now, I think it's the number 2 strain at the moment. That one seems to be holding steady, which means it's probably going to be on the way out. Most of the strains that are rising are relatives of JN1 and KP3, and both of those are covered well by the vaccines that are still available. So, as with what's the story by Dickens, A Christmas Carol?
Yes.
As with that, there is still time. Yeah, the clock hasn't struck midnight. We can still get vaccinated, and all of these diseases are on the rise, but we haven't hit the peak of any of these seasons yet. So there may still be some hope that we can do something about this before the viruses hit.
Thank you. Could you repeat the rising strains? I did not get them.
Oh, rising strain, JN1 relatives and KP3.
Okay.
There are subvariants of those, but everything that's circulating right now is related to one of those two things.
Thank you. We'll have a final round of questions from reporters. Our last speaker today is Dr. Maurice Pitesky, who joined us this summer to discuss avian flu. Dr. Pitesky, could you please give us an overview of what has changed in the past 6 months, especially since we've now seen a fatality from bird flu? Dr. Pitesky, are you on?
Nita, I think I see an email from him saying he's having trouble coming into the Zoom room.
Oh. Well,
Anita, I think the three of us can pinch hit.
I think so. Dr. Bhadelia, you had written extensively about avian flu. And I wonder if you could discuss avian flu with us in the absence of Dr. Pitesky.
Sure, I can start, but I think, as Dr. Schaffner said, I think we'll all be able to sort of pinch hit here.
Okay.
I think the concern with the current H5N1 outbreak in the United States has been since last spring that over the last 2 years, this virus that is very good at adapting and evolving has found itself in over 40 mammalian species, which were mammals, which makes it much easier for it to potentially evolve in the future to be better at infecting humans and causing more severe disease potentially, but certainly potentially causing sustained human-to-human transmission. The last a year almost, I guess, because we're in January now, the concern has been that the infection has made it into domestic animals, and particularly around cows, which are closer to humans, creating an environment in which the virus can come into closer contact with humans and cause human infections. But I do see Dr. Pitesky's on, so I will stop.
Hi, Dr. Pitesky. I'm so glad you can join us. Are you there?
Yep, I'm here. Sorry.
Hi, Dr. Pitesky. Very, very glad you could join us. So the question I had for you initially is, you had joined us over the summer to discuss avian flu, and I was going to ask you, what's changed in that period of time, especially since we've seen one death?
Yeah, so we're unfortunately in kind of an extraordinary situation here. So just for perspective, we've domesticated animals for agriculture for 7,000 years or so. When you look at this outbreak from a geographical perspective, it's on 6 of our 7 continents, including Antarctica. When you look at it from a species perspective, as the previous speaker alluded to, we have it in wild and domestic birds. We have it in wild and domestic mammals. We also have now humans that are kind of part of this equation also. The virus is also present in abiotic environments, so wetlands, lagoons, human wastewater. It is ubiquitous. It's endemic in North America by most people's kind of guesstimates at this point. So we're 3+ years into this outbreak, and it's expanded as far as species, geography, economic impact, food security, and unfortunately now public health for humans also.
Interesting. Is there evidence now of human-to-human transmission? I think that's the big question that.
Yeah, so I'm not a human physician, but I'm an epidemiologist and focus on kind of more the agricultural perspective. But the human folks will say there is no evidence yet of human-to-human transmission. I think it's also important to realize we don't have a very good surveillance system up for the workers that have the occupational risk, whether they be dairy workers or poultry workers. And the real risk is that because we don't have good surveillance, that if the virus continues to evolve and mutate and does show the potential for human-to-human transmission, the real worry is without a surveillance system, we're not going to capture that as quickly as we need to. And you have this worst case scenario of someone coming home from a dairy or poultry facility being sick, exposing not only their family, but a lot of the folks that are in these kind of industries lived with in mixed family, mixed generational homes. And the virus can spread significantly before we really get a handle on what's going on. And as we all know, prevention is much less expensive, much easier to deal with small outbreaks than large outbreaks. So we're definitely teetering. And one thing I've had people ask me in the past, like, well, can you model what's going on? And in the past, our lab and others have tried to predict where the virus is going to move. And I always tell people, no, it's way too complex at this point. We're not just looking at wild birds, ducks and geese, and poultry. Now we're looking at in humans and wastewater and so many other different wild species that it would take the rest of our time to list all the different risk factors. So all the different species affected. So we haven't really stayed ahead of the virus in a sense with respect to surveillance and including on the human side.
And there have been calls for vaccinating all farm workers. Do you agree? And will our current flu vaccines work here, or do we have vaccines specific to for avian flu?
Yeah, I'll speak to this just a little broader because I'm not a human physician and I don't study vaccines per se, but offering the vaccine to humans, the influenza vaccine, is definitely good practice in the sense that one of the worst case scenarios is that you have human influenzas and avian influenzas co-infecting either humans or other species and reassorting into a highly virulent, highly infectious virus. So by vaccinating against human influenzas in people that are at risk, specifically poultry and dairy workers at this point, but probably other agricultural workers that work around food animals, we would potentially reduce the risk of that reassortment happening. So it does make sense. One of the real challenges, as we just mentioned, and I'm sure others have mentioned, is the issue of how do you vaccinate populations that are, have high proportions of undocumented workers? So we need to be able to access those groups, and we need to have a really robust collaboration, which we don't have right now, between the Departments of Public Health, the CDC, and the poultry and dairy industry.
Yeah, and before I ask you your last question, Dr. Pitesky, I'd like Dr. Bhadelia to weigh in on this as well. You had called for vaccinating all farm workers.
Yeah, I've been last spring and summer, what I've been asking specifically is what Dr. Neuman mentioned in the chat, which is our stockpile vaccines for H5N1 are against an older subtype for a candidate vaccine. And so it's not for the currently circulating B313, which is in animals. However, the ferret studies that CDC did showed enough, neutralization action, I think, against the current subtype that making it available in it's already approved. That vaccine is already approved. Making it available in a limited voluntary way allows you to at least find those farm workers that may not be, healthy workers population, but potentially may have medical vulnerabilities in whom the infection may not appear in the same mild way that we've seen in many of the current farmers in which the infections have happened. Since then, though, currently, and as Dr. Chinhong was saying, there's about 5 million already, and they've actually asked for another 5 million that would be funded this spring. However, we don't have 5 million farm workers. If we really wanted to vaccinate them, we could. It's the issues are what Dr. Pitesky was saying, is actually being able to set up an infrastructure that targets and allows migrant workers to be able to get it. At this point, though, we have new candidate vaccines that are in the works, and it makes actually more sense to make those available under expanded access, my opinion already, only expanded access programs, because my background is I ran a special pathogens unit backing up our biosafety level 4 laboratory, in which many times occupational at-risk lab workers were offered promising vaccines under limited research protocols for exactly this kind of issue. And in that world, in that specific thing, it's kind of similar to what we're seeing here, particularly if we see, the subtype D1, which has caused the more severe disease in the Canadian teen and the death in Louisiana. If that becomes more widespread, that's something that we need to at least get ready and start thinking about making available.
Thank you. Dr. Pitesky, you had mentioned at our last briefing that you have concerns about underreporting of cases, given that this is a particularly vulnerable population. Many folks are undocumented and hesitant to maybe reveal their illnesses. People lose a day of work if they talk about being sick. Do you have concerns of underreporting of cases?
Yes, I mean, I still have that same concern. I think one of the things that I think is a potential solution, and I'm not a policy person, but one of the things that I've kind of tried to float to the industry and to anyone that would listen in the government is the concept of what I call a high path AI grand bargain, where indemnification would be guaranteed for dairy, poultry, swine, whatever industries affected. So they get this economic security in exchange for access to the farm workers that are doing the work on the farms. Right now, we just don't have that. We don't have this ability to go onto farms, to educate, to vaccinate, to provide PPE. It's just not robust enough. And how can we create an incentive? And using my favorite behavioral economic term, how can we nudge people to do kind of the right thing? And we've had this problem for a year, and we've had this problem historically. So we need to figure out a policy that helps nudge the farm workers, the companies specifically, toward the table. And if we can indemnify the industries as we currently indemnify the poultry industry, there's probably potentially some value there to help workers, hopefully.
Thank you, Dr. Pitesky. We now move to our 30-second sound bites from each speaker. Dr. Chin Hong, I know you have to get on another briefing, so I'll start with you.
Yeah, so my few second soundbite is that we focus on technology like new vaccines and tests, but it's always the implementation of the technology that is really the challenge so that all populations can benefit locally and globally.
Thank you so much for joining us. Dr. Bhadelia. You're muted.
I'm just going to say ditto to Dr. Chin Hong, because I feel like we don't say that enough. Silver bullets are only as good enough as how many people we can get them to.
Thank you. Dr. Schaffner.
Well, just to reiterate, vaccines don't prevent disease. Vaccination prevents disease. And what I'm concerned is policies going forward that will erode our capacity to deliver vaccines comprehensively to the population and further reduce trust in public health.
Thank you, Dr. Schaffner. Dr. Pitesky.
There are no short-term solutions. We need to think in the medium to long term, and we really need to put some thought for the first time in trying to, as best as possible, habitat shift, create new habitat corridors for wild birds away from where we grow our food.
Thank you. Last word, Dr. Neuman.
Yeah. Decreased vaccination uptake and the change in funding mechanism that puts the cost back onto the person or their insurance, along with a change in administration, has to lead to decreased incentives to vaccine makers to make new vaccines. And that, I think, is a big long-term problem that we have yet to address.
Well, thank you to all of our speakers today, and reporters, thank you so much for joining us. We will see you next Friday. Take care.